think we can cure a certain subset.
I think your point about neuropathy is so critical. I find that oftentimes our discussions regarding when to stop the taxane is both a mix of response and tolerability. And on that same vein, I think thinking about the how robust the response is. So are we achieving a complete response? Are we achieving a partial response? In my experience, it's oftentimes a partial response where we decide to stop partly because we've achieved a response, but also partly because of toxicity. Sure. What has been your experience in terms of response to THP? Have you seen a lot of CRs? I certainly think that this is an opportunity for improvement, but curious in terms of what you're seeing.
Yeah, I think that's part of the challenge that we have, because we have a lot of patients over the years that have long-term durable responses to HP. But we forget about all the patients that have progressed on therapy initially. So the anecdotes of the long-term responder really makes us look at the regimen sort of with a very emotional eye. I think this is clearly possible. And I've had patients, and I think an individualized discussion where we stopped HP, where we felt this was so deep of a response, where we had both imaging negative, and I like to use a lot of ctDNA and ctDNA negativity at the same time, that we even stopped HP. I think we can cure a certain subset of HER2 amplified breast cancer. But the question is it the majority of patients? And it's clearly not. We have a durability. I would like to go as deep into deep of a response as possible, but we oftentimes really limit it, and there's some intrinsic resistance mechanisms that we have to account for as well. So it's a really a big clinical judgment balance.
Well said. Yeah, I think your points, you've made so many interesting points here, and we're in an interesting phase right now where we're de-escalating therapy, but we're also escalating therapy. And I think about it in terms of getting back to your point about maintenance therapy, induction and maintenance therapy, and perhaps if we're strategic about where we escalate therapy, or at least where we use more effective therapies, then perhaps it'll set us up for more successful either maintenance or even the curative approach that you alluded to, the elusive curative approach. And I think trials like the Stop Her trial and ongoing trials in that vein will be helpful in terms of addressing whether or not we can achieve that. But for now, I think that successful induction is really critical. And for a long time, the successful induction regimen was indeed Cleopatra, as you've been discussing. But let's move to more recent data that you've been alluding to, and certainly DESTINY-Breast09 was a game changer in terms of what we see in the in terms of tumor response and the induction setting. Could you walk us through DESTINY-Breast09 and your thoughts about how these new data may be incorporated into the new standard of care?
Absolutely.